So, Dr. Uboha, thank you so much for talking today about an exciting time in metastatic colorectal cancer. And I think we're seeing a lot of advancements with biomarker-directed therapy for colorectal cancer. And we're seeing a lot of new data in this space around KRAS G12C inhibitors. And I just wanted to kind of get a sense from you, what was the rationale in targeting KRAS G12C and how is that impacting colorectal cancer?
Dr. Liu, thank you so much for having me for this discussion. It is an exciting time in targeted therapy for patients with GI cancers and colon cancer in particular. It is exciting to see KRAS inhibitor entering clinics. And this study used a very specific KRAS inhibitor, KRAS G12C inhibitor, Adagrasib, in combination with Cetuximab, as well as monotherapy in patients with particular alterations. And so this study enrolled patients with colon cancer that have KRAS G12C mutation. In contrast to lung cancer, G12C mutations in KRAS are not common in colon cancer patients. We usually see mutations in KRAS codons. We usually see mutations such as G12D or G12D in this patient population. But regardless, even though it's only 3 to 4% of patients that have this mutation, the fact that we see impressive efficacy of this combination will move the needle in this disease. So Adagrasib is an FDA-approved agent. It's an irreversible KRAS G12C inhibitor. It is already approved for the treatment of non-small cell lung cancer with this mutation, where we see KRAS G12C mutation much more frequently. And so Crystal-1 looked at this drug in combination with Cetuximab, as well as there was a monotherapy cohort that was included as well in advanced colon cancer with KRAS G12C mutations in patients with advanced colon cancer with this mutation.
Thank you for that information. And exactly, we typically see this mutation in about 3 to 4% of patients with metastatic colorectal cancer. So a small, but now very actionable group of patients. And so when we look at the Crystal-1 data, we know that this was a heavily pretreated population, right? So tell us a little bit about what we saw in terms of the effectiveness of the drugs.
You're right. Median prior lines of therapy was 3, in this study. And what we presented in the most recent publication is data from 94 patients that had a follow-up time of 11.9 months. What we are seeing is the combination of Adagrasib and Cetuximab resulted in a response rate of 34%, which is impressive. This is a chemotherapy-free regimen. We have not seen these types of responses with any other agents this late in the treatment. So it's encouraging to see this, and it again stresses the importance of molecular profiling and NGS testing and biomarker testing in this disease as well as other diseases.
Oh, absolutely. And agree. I think that response rate is really astounding. And again, like you mentioned, in just a really heavily pretreated population. Also, of course, with the biomarker testing, you're right. I mean, got to find the biomarkers and we have to test early in the course of the patient's treatment as well. Tell me a little bit about tolerability in terms of the combination of Adagrasib and Cetuximab in these patients. What were some of the more common side effects that we saw with the regimen?
We've seen GI side effects with Adagrasib, which is what we've seen from other studies as well with this agent. Nausea and vomiting are the most common side effects. And then, of course, because this drug was used in combination with Cetuximab, we've seen expected anti-EGFR toxicity, rash, and diarrhea. But there were no treatment-related toxicity that led to Adagrasib discontinuation, which is encouraging.
Yeah, that's actually really, really impressive and correct. I think we've seen this with several KRAS G12C inhibitors, but good to know that the regimen was very well tolerated. So a rapidly evolving field, wild that we're talking about targeting KRAS, wild that we're talking about targeting KRAS effectively, even if it's for a small subset. There's a lot of emerging data. I'm sure practitioners and providers want to know, how are you incorporating this data into treating your patients with KRAS G12C mutations and metastatic colorectal cancer?
First of all of my patients undergo extensive molecular profiling at the time of diagnosis. I've shifted from putting in my notes in clinic, KRAS mutant or not, to actually putting letters and numbers after KRAS. It's amazing it's becoming important. And honestly, whenever we see, and again, it's not frequent, but when we see mutations in the KRAS G12C, we are moving these targeted therapies into earlier lines. It's hard to incorporate. There's no data to use this in the first line. However, I think it is a very good option for patients to consider in second line or after progression on 5-FU-based therapies.
Absolutely. It is kind of nice to sometimes even give patients a break from chemotherapy. And it's nice if we have a targeted therapy option in the second line setting and beyond. So very great.